Hi, everybody. Welcome to the start of a brand new series I have been working very, very long and hard on. I'm very excited to present to you Curious Psych Roles. And I thought of this because I wanted to know myself, what kind of psych jobs were there out there besides just working in an office or working in a hospital? And what I found is that there's all sorts of different jobs in the psych world. So to celebrate the beginning of our brand new series, we were joined today by a very, very special guest who is going to tell us all about his experiences working with the LGBT population. And this topic is very hot right now as more and more people are being aware about LGBT issues. And so I thought this would be a very great time to bring light to the people who work in this particular population. And if you stick all the way to the end, we have a very, very special presentation from Mr. Robert himself, who's going to help educate us all on the nuances of working with the LGBT population. So if you're really interested about working with this group, then definitely stay all the way to the end because you're definitely going to learn a lot.
Yeah. Well, first of all, thank you, Joyce, for having me. It's a great honor to be part of this. Because like you mentioned, I think now the discourse and the conversation about the LGBT population is starting to be put more in the front, right? Even in our politics, I feel like now it's being talked a little bit more about the LGBT population, and so I think it's very important, for people to be educated about the population. And so my name is Robert Jimenez. I'm a psych MP. I work for the LGBT Center in LA. It's the world's largest LGBT center, and so I have that great opportunity to be working with a population that I myself am part of.
On that note, can we talk about how you even ended up in this role? Was this something that you knew you always wanted to do, or can you tell us a little about your nursing journey?
Yeah, so ever since I can go all the way back to since I was a kid. I remember, and this is where it all first started. I was in first grade and I got sick and I was sent to the nurse's office. And when I was in the nurse's office, I remember seeing all the medication, the equipment, and I was like, oh my God, this is so cool. I was just so in awe by all of it. And so ever since then, I knew that I wanted to get into the medical field. And then so, obviously as I graduated and then all that, I started thinking more about it. And I first thought I was going to go into medical school, but then I realized how much of a burden it is for doctors and for them to all the responsibilities that they have. And so I was like, well, what else can I do so I could still be in the medical field? And that's where the whole thing with nursing came into play, right? And then I started back in 2005 because I had moved from Texas to California, and so it took me a good 10 years before I finished all my prerequisites and finished my associate's degree. And so I did my associate's degree in nursing, and then after that I did my bachelor's online, and then right after that I went into my master's program. And no, I didn't think I was going to end up, in psych. I didn't think I was going to end up working with the LGBT population. It just happened to it just happened. An opportunity came about. I don't know if you remember, Joyce, but we had that someone come from the LGBT Center the week before we were going to be done with the whole program and talk to us. Well, I know that individual because when he was going through nursing school, he was actually shadowing me at the Long Beach Health Department because he wanted to get more work in with regards to the HIV population. And so that's how we met. And then so we exchanged numbers, but we didn't really keep in contact until that day when he showed up to class to do the presentation. I was like, oh my God, hey. And so and then he was afterwards, I need to talk to you. And then that's when he was like, hey, there might be an opportunity at the LGBT Center, send me your resume. And I was like, are you serious? Yeah. I was like, okay, fine. I sent him my resume, and then it just happened. I got the call, I think it was on a Thursday when he went to go present. And then that Monday, the following, I got the call from the doctor there, and he was like, hey, come in for an interview. I got interviewed, and the next thing you know, I'm working there. I
had no idea. I had no idea what happened. Wait, yeah. So for our viewers who don't know, so it sounds like you worked at an HIV clinic as a nurse first.
Right.
Do you feel like that experience really helped you in transition to LGBT, or?
So yes, it did, and that was also kind of part of the reason why I got kind of guided into psychiatry, mental health, because I worked at the Long Beach Health Department and I worked at the HIV clinic, and that's around the time when PrEP was coming out. And for the viewers that don't know what PrEP is, it's pre-exposure prophylactic, and that's just basically patients who are MSM population. It's men who sleep with men population are given an HIV medication, whether it's Truvada or Descovy, and it's a preventative measure for them not to acquire HIV. And so they're basically taking it daily on a daily basis. And so if they were to come in contact with the HIV virus, it will stop or prevent the persons from becoming HIV positive. And so the majority of the patients that I saw in that study that I ran at the Long Beach Health Department were, gay men. And so, and part of that study also was, it had to do a lot with behavioral change. And so there was a lot of MI components where I had to do MI with regards to behavioral change and whatnot. And so the patients would always be like, oh my God, like, you're so good, like, you should be a therapist. And so then that's when it started, like, wait, like, maybe I should go this route. And then that's when it like started like sinking in. And then so Keegan, the student that I mentioned earlier, the one who went to present, he was also doing the psych mental health nurse practitioner. And so he shared about it. It's like, oh my God, like, this is perfect. And so then that's how it came about for me to be doing or getting into psych mental health, because of that experience and because of like the feedback that I was getting from the patients. Do I feel like it prepared me? I'll be very honest with you. No, I don't feel like it did. I kind of had an overview, but not compared to like my other classmates. The example yourself, that you had worked in psychiatry before and you had like all these years under your belt. So when I went in there, I can honestly say that I was lost. Right, I was a bit lost because I mean, this was like having to learn a whole different, like I was in HIV. So
Right.
This is a lot of specialty. Like I'm going into psych mental health, like now the new psych medications, like all these other different terms that I have to learn. And so it was a bit daunting and it was a bit scary, to be honest.
So I'm glad that you mentioned that, because so what kind of experience, if somebody's interested in working with the LGBT population as a psych nurse practitioner, what kind of experience would you recommend that they get?
I don't feel like there needs to be any type of experience, but I think it's more of having an open mind and coming from it from a place of non-judgment, right? And trying to be understanding that. And I say this because I feel like a lot of the times, as providers, based on our own experience, when we see patients that are not from our culture or, whatever, right? There sometimes can be some, prejudgment or, based on our own experiences. And so I feel like having, being self-aware and knowing what's yours and what is not yours, it can take you a long way. It can definitely help you in this specialty. For me, it was a little bit easier because I have no problem disclosing that I am part of the community. So for me, it was a lot easier for me to like step into that role. But not to say that we have providers that are not part of the community and they're just allies, and it's like, to them it's like, because they're aware, they have friends, they know like the culture, they know like the terms that are used, and they're not whatnot, that I feel like they have like a better understanding of that population, and so therefore it's a little bit easier for them to like step into that role. I don't know if there would be, I mean, maybe that's a good thing, right? Maybe like looking into someone starting a training, so if people would want to get into the
I think so, because you mentioned a bunch of terms like allies, culture, like being part of the community, and I don't think those are necessarily terms that, unless you are already part of the community or if you are already an ally, you have to really look for that kind of education, right? I would say.
Right.
They don't really teach you that necessarily. Luckily, at our program, because we went to the same school, we did have somebody come here to educate us all on that. But I mean, are there any like resources that you might suggest for somebody that wants to learn more about what it would be like to be like an ally or be part of the community or anything like that?
I mean, if anything, like I'm sure there's like tons of resources that they could find online. I have a presentation that'll show you and discuss like all the different terms and whatnot. I don't know specific because again I'm part of the part of it. Like I didn't have to go do research on my own. Like I am part of the community.
There is a community out there, and they're more than happy to have you learn about their community.
Exactly.
Yourself.
Yeah, I saw like, okay, well, let me go do research on what it is to be gay. Like I myself am gay, so it's like. So that's why it's hard to like to answer that question because you know,
it's also good to know though that you don't have to be part of a community to work with this setting. I would probably say it's like a majority of your coworkers part of the community okay, yeah, it makes sense. It makes sense. Like you know the population, and then that's why you're very passionate about it. It's typically what you're exposed to a lot. I also have another question: is there any stigma about mental health in the LGBT community?
Yes, there is. I feel like that's just overall. It's not just the LGBT population. I think overall, there is stigma in mental health. I'm starting to see a shift.
Okay.
Like I'm starting to see a shift, and I think that's again overall, not just with the LGBT population. I feel like overall, like I feel like that stigma is like it, and I think I hope to see, given the like right now with the pandemic going on, it's going to be more acceptable, right? Because like all of us experience this pandemic, right? And so like all of us experience this, and so then there's a lot of depression, there's a lot of anxiety because of the stay-at-home order and all this stuff, right? And so I'm hoping that with this pandemic, like the result's going to be that more people are going to start seeking mental health services, right? Because it's going to be more acceptable, or the stigma's not going to be there because we all experienced the pandemic together, and so. But ultimately, like when I first started working, yes, at the I mean, I think generally just mental health. There's always been that stigma behind it, and people, I got this, like I don't need the mental health, like I can do this on my own, and all that, and it's all again like it all has to do with again culture, and that's a stigma. The stigma is a big one that prevents people from getting services.
So when you do eventually see people, when they do come in, are there any conditions or disorders that are more prevalent than others might be?
In my experience, yes. There is a lot of complex trauma.
Okay.
There is a lot of that within the LGBT population. Just PTSD. And so... that's the one that I see the most. I mean, if you think about it again, like, the LGBT population, right? All the trauma, all the abuse, and everything that they experience, right? The majority of them do. And so they come in with that depression and anxiety, panic attacks. Anxiety and panic attacks would be like up there with PTSD, CPTSD. It's not that common to see schizophrenia. I do have a patient, and then like, amongst my other colleagues, like whenever we discuss or talk about patients, it's not very prevalent, but it's bipolar disorder and borderline personality disorder.
And what kind of so definitely with a lot of those disorders, the PTSD, the complex trauma, the borderline personality, I'm imagining there will be a very significant therapy component to the treatment as well, right? Yeah. So how does you work at the LGBT Center, so can you tell me, who do you collaborate with? Is it just you by yourself?
So no, we do have a multidisciplinary team. So we do have mental health, and then we do have primary care as well.
Okay.
And so yeah, we do a lot of collaboration. So I refer my patients out. I tend not to refer my patients to the therapy at the center because it's very limited. They only get 16 sessions, and so I know that, again, because of my experience working there, I know that they require longer periods of therapy, not just 16 sessions, right? So it's for very acute situations that, someone might have gone through and they want to resolve or process. Then yes, absolutely, that's the only thing that, that happened to you. Let's say their pet died and now they're extremely depressed. And so get into therapy for 16 sessions because I'm sure that'll, help you. But a lot of the patients, again, come with all this trauma from the past, and then trauma that they're experiencing in the present as well, with relationships, with substance use, with all this other stuff, right? And so the majority of patients, I always just refer them. I always tell them, if you have insurance, find a therapist outside of the center, because like that, you can start building that rapport, and then you're not going to have to be worried about, I only have 16 sessions, then the sessions stop, and then now I have to wait another year before I can get into the center again. And so it's just rather easier to just go outside of the center. And then I always let them know, depending on what their symptoms are. If I tell them, oh, you might want to look for DBT, or you might want to look for CBT, or you have a lot of trauma, do some EMDR, and so I always kind of refer and always tell the patients to kind of, look for certain types of therapies that I feel like is going to be beneficial to whatever symptoms or whatever their diagnosis is that they're experiencing.
What is your most favorite and least favorite part of your job?
My most favorite part of the job is that I work with the population that I belong to. That's in and of itself is amazing.
Yeah.
Right. And so it makes it easy for me to be able to, and not necessarily relate, because everyone's experience is their own experience, and everyone's unique, their unique experience. Even if it's similar to what I've been through, what I experienced in my past, I can still say that I relate, right? Because that's their experience, it's my experience. And the hardest thing is whenever I'm not able to help, or I'm not able to make a difference in someone's life. That's the hardest part. When they're either too much in the substance use, or the patients that don't follow back up, and they're just nowhere to be found, or the patients that are just too chronic, and I need to refer them to elsewhere for them to get help. That's the hardest, because I feel like I wish I could help every single patient that walks through the door. That's not the case. Yeah. And if that's something for your viewers, just know that's when I first started, I'm like, oh my God, I hope I can help everyone. I hope I can make a difference in everyone's life. Not the case.
Not the case. Not the case at all. It just sounds like it's just working in this field in general. Just with the nature of our population being in mental health, there's so many barriers. Some of them put up by, the outside, some of them internal barriers, and it's the most heartbreaking thing not to be able to help your patients, and you care so much.
Yeah.
That definitely can get very challenging. So, I mean, how do you take care of yourself then?
Oh, I do a lot of. I was doing a lot of running, and so I fell off. And it's funny, because it's we as providers, we're educating our patients for self-care and for them to do all this thing, right? And then I'm starting to, where I'm going with this. That's why you're laughing. And so here I am, right? Educating someone, and then I catch myself, I'm like, wait, what am I doing? If I'm not doing this, what right do I have to be oh, hey, you might want to go do some exercise, you might want to do some meditation, if I'm not putting it into practice myself.
Yeah.
So I was doing really well, and then I fell off. So now I'm starting to get back on it, where I'm meditating. I do a lot of meditation. I do a lot of exercise, and then running. For me, running is another form of meditation. I live by the beach, so it's easy for me to, drive over to the beach, and there's a beach path, and I do 2.5, 3, sometimes even 5 miles. And that just, yeah.
I should put that as my New Year's resolution. I knew exactly where you were going with that. I was like, oh man, straight to the heart.
It's true, right? Isn't it true though?
It's true. It's so true. We are the worst. We are such the worst. It really is and it's not like, I always mean to do all these things and implement it, but it's hard. It's hard. And that's part of the thing that I tell my patients too. Is like, I'm telling you all this stuff, but I know it's difficult because it's hard for me too. So it's a journey. It's a journey.
Right.
Go through it together.
Exactly. Yeah. I'm the same way with my patients too. I'm always like, look, I can't say that I get it because I am not you.
Yeah.
But it makes so much sense why you are in this space, why it's so difficult, why you're having this experience. Because let me tell you something, I'm human myself.
Yep. You're absolutely not perfect.
Yeah, exactly.
Sorry to burst your bubble, guys. Okay, and somebody wanted to know, what does your typical day look like?
So my typical, I do 4/10s. So I work Monday through Thursday. My day starts at 8 o'clock, and so I am scheduled anywhere between 10 to the max 13 patients a day, which I've heard that it's on the high side for some people. But I mean, to me, it's like, oh, it's fine.
I think it would depend on, are you doing like hour initials and half-hour follow-ups or?
Yeah, I'm doing hour initials and half an hour follow-ups.
That's pretty, that is kind of on the high end, I would say, for like a community health setting. Yeah,
it is. And at the same time, it's like, it's not that common for like all my patients to show. So like there are, no-shows. I'll, have 2-3 no-shows, right? So it's still, I guess, on the high side, right? If I have 13 patients scheduled and 3 of them don't show, it's still 10 patients that I did see.
That's still a lot.
It's still on the high side, right? But I've been this is what I started doing, and so to me, I don't know different. So, and I guess I've shared this with other psych MPs. They're like, oh my god, like you're seeing how many? And I'm like, yeah, like isn't that like how everyone's doing? But it's like, no, like.
To clarify, I also work in community health setting, and on a busy day, maybe like 8. Everybody shows up. So more so, it's like 4 or 5, maybe 6.
Oh my god!
I know, that's what I'm saying. Like, wow, that's a lot. But I mean, so if you see all those patients, then what time do you actually get out of the office?
So I feel like I've gotten really good with my charting, and so like now like I'm done like once because it's my shift is from 8 to 6:30. But like so for instance, I start out at 8, and then from 9:30 to 10 I have admin time to catch up with the morning patients if I need to chart. Like I have half an hour for me to catch up in the charting, and then from 10 to 11:30 I see patients, and then from 11:30 to 12 I have admin time again, and so I can catch up on those. And then from 12 to 1 is my lunch, and then in the afternoon from 1 up to 2:30 I see patients, and then 2:30 to 3 I have admin time, so I can catch up. And then at 3 to 4:30 would be my last patient schedule. And then so let's say if the 4:30 shows up, by 5 I'm done, and then from 5 to 6:30 is my admin time. And then so I'm able to catch up on my charting, or patients need refills or paperwork that needs to be done, or if I need to call a pharmacy, all the other stuff that goes with being a psych MP, not necessarily just seeing patients, right? It's all this other
All
paperwork.
the terrible stuff. The worst
Yeah,
part.
exactly. That's the part that I'm just like, oh my God, like, do I have to really do this? And the disability, it's
Oh my gosh. Oh, the forms. For me, it's the prior auth. I hate the prior auth. It makes me so mad.
I'm really fortunate because we have a pharmacy there as well at the center. And so our pharmacy, like if we send the medication there, our pharmacy takes care of all that. The prior auth forms, everything. We don't have to do nothing. The only time when we have to is when we send them out to like Walgreens or Rite Aid or all the other pharmacies. That's when we have to do all the TARs and the pre-auths and all that other like forms. Yeah, it's just
That's so nice.
so much. But because I've had to, because some patients are like, oh, I don't want to get my medication at the center, so can you please send it to Walgreens or Rite Aid? And so what I do, and if it's not, the insurance throws it back, and so, oh, like it needs a prior authorization. I'm like, oh. But, we found a way, and so like I'm able to convince my patients, I'm like, hey, is it okay if we send it this first time to the pharmacy here at the center so they can do the prior auth, and then once it gets authorized, we can send it to the Walgreens? And like, oh yeah, that's fine. Like just this one time, because Walgreens doesn't do their prior auth, so like they send it to me, and it's a lot of paperwork, and then the patients are more like, oh, okay, yeah, it's fine. Like it's just going to be for this time. Like don't even worry about it, because once it gets authorized, then we can send it to whatever pharmacy you want. And so we found a way around it, and so like now if patients request, I'm like, hey, it didn't get authorized, can I send it to the pharmacy here?
That's a pro tip right there, guys. Yeah. That's coming from seasoned expert, seasoned veteran. Okay, so somebody wanted to know, are there many opportunities available for new grads, and if you need special training for it? I think you answered it a little bit, but
yeah, no, I mean, again, if someone is wanting to work with a population, you don't need specialty training or anything like that. But then I can't base it off of my experience, because again, I'm part of the community. So when I walked in there, like they asked me like, why do you want to work here? I'm like, because I'm part of the community. And so I was like, oh, okay, well, but again, like, so it's right now it's one psychiatrist, and so it's 4 nurse practitioners. And so like the other 3 nurse practitioners are they're allies, right? And so so what allies, I mean, it's part of the presentation, but what allies is basically just what the word, it's an ally, right? Like they're not part, they don't identify as LGBT, but they're allies to the community, like they're for the community, but they don't identify as LGBT. And so, I mean, yeah, so like the psychiatrist, there's 4 nurse practitioners. With regards to if there are any opportunities, they were going to hire another psychiatrist this past year, but because of the pandemic, like everything was placed on hold. And then they're thinking about possibly hiring another psychiatrist this year, because it's already been budgeted, it's already been approved. Like it was already going to go through. They were already going to start putting it out there to try to recruit a psychiatrist. But again, the pandemic hit, so that had to be placed on hold. And so like they're thinking that this year they're going to move forward with it, because they opened other locations, other LGBT centers. And they opened one in South Central, they opened one in East LA, and one by downtown LA. And so they want to hire another psychiatrist because they want to get 4 more nurse practitioners. And so in the future, there probably more than likely will be opportunities for nurse practitioners to potentially get hired. So I can always keep you on the loop and see if your viewers, if it does come through, or if it does happen, then I can definitely send you the information.
What if they don't live in California? Where would you, yeah, because not all of our viewers are in California.
Oh, got it. Yeah, I would say to just find the nearest LGBT center to your area, and then maybe ask to see if they have any openings or any positions available for psych MPs. I just know that the LGBT Center, the LA LGBT Center, is the largest LGBT center in the world.
Is it really? That's
Mhm.
awesome.
Yeah. It's the largest in the world. And so I know that a lot of people that's part of the presentation as well, but a lot of people from, from other parts of the country, they come to LA specifically to come and get care at the LA LGBT Center.
Well, there you go. If you want to work with LGBT, move to LA. That's awesome. Okay. And I think we just have one last question for you today. And it's, if you have any advice for anybody that's going to be starting this field, any aspiring nurse practitioners, do you have any advice for them?
I can speak on behalf of my experience. Again, like I mentioned earlier in the interview, it was a bit daunting and a bit scary for me. Again, because I hadn't worked, and I didn't have that much experience in the field. Ultimately, I was able to get through, and as scary as it was and as daunting as it was, it's just a matter of just doing it. But that's just me. That's just my experience, and that's just my personality. That even if there's that fear, even if there's that self-doubt, even if there's that I'm not going to be able to do this, I'm not going to be able to make it, I always push through no matter what. I just let those thoughts be there, right? Because I feel like it's okay, like they both can exist at the same time. Those thoughts of me having that self-doubt and that fear can exist, as well as yes, I'm going to do it, yes, I'm going to make it, right? It's okay, there's nothing wrong with both of those existing at the same time, which is something that I didn't realize while I was going through the program. And so if there's advice I can give, if you do come to that place where you're having that self-doubt or that fear, or whatever it is, negative thinking, just know that it's okay to have those thoughts, and also for you to have that, I am going to do this, I will do this, I will get through this. And it's okay for both of them to exist, but not allowing for one of them to overpower the other one, if that makes sense. And I feel like I didn't realize it after the fact that I was actually doing that. I was allowing for both of them to exist. I was allowing for that self-doubt, for that, oh my God, I don't know if I'm going to be able to do this. I was allowing for it to be there because, it's part of who we are, right? We're human beings, so we're going to have negative emotions. We're going to have positive emotions, right? It's not allowing for one or the other to, it's not allowing for that negative to overpower, yes, I'm going to do it. And so I hope that helps.
That's an amen. That's an amen. That's such a great message. And even if you have experience, it's still extremely daunting. It's a new role. You've never done it before. Anytime you move to a new job, no matter what it is, you're always going to feel that sense of oh my God, I don't know what I'm doing. So it's a great message.
Yeah, no, absolutely. And I always, I guess again, that's why I said I speak from my experience, right? Because I would always see my other classmates that, had that experience. I don't they know the medication, they know the dosaging because they've been there, they've experienced it. So for me, I'm having to learn all the medications, I'm having to learn all the dosaging, I'm having to learn all the side effects, I'm having to learn all this other stuff, and they've already been in this field, so they already know the words, they already know the names of the medication, they already know the dosaging, so they're already kind of a little bit ahead than I am, right? Because I'm having to learn all this from scratch. So I guess what I'm trying to say is that it doesn't matter what experience you bring to this, it's a matter of just doing and moving forward and just doing what you have to do, because it's even for people who are seasoned in this, that have that time and that experience, they still experience the same feelings that someone that's fresh, that didn't know anything about psychiatry. So it's just a matter of just doing it. Just do it.
Yeah, just do it. Just do it.
Nike, right? Just do it.
No, sponsor me. Okay, well, thank you so much. That was very, very, very inspirational and very, very educational. And I know you have a presentation if you want to share your screen.
Yeah, of course. We'll go through this quick, but then it's going to give you an overview of the LGBT population. Well, you'll see. LGBT mental health, the epidemiological overview. And so these are going to be the learning objectives: identify epidemiology of mental illness and substance use within the LGBT community, identify potential causes, aggravating factors of mental illness and substance use among LGBT people, identify the limitations in this area of research and future improvements that can be made, and identify and employ specific interventions to reduce mental illness and substance use within the LGBT population based on current research. And so here are the terms: sexual orientation. What is sexual orientation? It's an enduring emotional, romantic, sexual, or affectional attraction towards others. Sexual orientation exists along a continuum that ranges from exclusive heterosexuality to exclusive homosexuality and includes various forms of bisexuality. Terms: biological sex, gender identity, social gender role. So sexual orientation is easily distinguished from other components of sexuality, including biological sex, gender identity, the psychological senses of being male or female, and then social gender role, which is adherence to culture norms for feminine and masculine behavior. And so there's increasing variety of ways to identify queer. Before it was a term that was very derogative. But this particular term, the youth, they kind of took it back to describe themselves and other community, and then to reappropriate it from earlier negative use. And so now it's used like, again, like it can be like, oh, like that's so queer, or I'm queer, or this is a queer community, right? It can be used in that way, and it's not seen in that negative connotation that it had before. A lot of the older LGBT population, they don't like this word because they associate it with their traumatic experiences that they had when this word was used in a derogatory way. The next term is cisgender, and it's a term that is used to describe an individual whose gender identity aligns with the one typically associated with sex assigned to them at birth. In this case, like if I was assigned male at birth and I identify with male, then I would be a cisgender male, right? And so that's kind of how the term is used. The next is asexual. It's an individual who does not experience sexual attraction. Gender non-conforming. So this seems to be outdated. It's like now it's like kind of like non-binary that is used. But it's basically used to describe to those who view their gender identity as one of many possible genders beyond strictly female or male. So it would be gender non-conforming or non-binary, right? Binary meaning male, meaning two, right? And so the next term is pansexual. So it's a person whose emotional, romantic, and or physical attraction is to people of all gender identities and biological sexes. And then there's intersex differences of sexual development. Individuals born with ambiguous genitalia or bodies that appear neither typically male nor female, often arising from chromosomal anomalies or ambiguous genitalia. And then there's others like polyamorous, demisexual, and more. So meta review, 25 studies, a total of 214,344 heterosexuals and 11,171 non-heterosexual people. And so the data from higher quality studies showed that higher cumulative incidence of suicide in lesbian and bi schoolgirls. And there was also an increased lifetime risk of suicide attempts in gay bi men. There's also an increased 12-month risk of suicidal ideation in lesbian and bi women. And in lesbian, gay, and bisexual people, pooled risk for racial lifetime risk greater than 2.47, which is kind of on the high side. The risk of 12-month prevalence of depression in the LGBT people on meta-analysis was at least twice that of heterosexual controls, with little heterogeneity. And then the risk ranged from 1.57 to 3.74. And then the meta-analysis of the data on 12 months prevalence of anxiety disorders in a pooled RR is for 1.4 for both sexes and 1.8 in the with little heterogeneity. Let's see. And then there's the MIDI studies. It's a survey that was done in 1984 from a sample of 2,100 LGBT people. And again, bisexual men were 3 times more likely to meet the criteria for major depression and 4.7 times more likely to meet criteria for a panic disorder than were heterosexual men. And then nearly 20% of the gay bisexual men overall were comorbid for 2 or more disorders, a prevalence exceeding that seen among the heterosexual men. Only generalized anxiety disorder appeared more prevalent among lesbian and bisexual women than among heterosexual women. And then for substance use, little consistent prevalent data, mostly comparisons. There are early studies up to 1/3 of gay men and lesbian abuse alcohol versus 13% lifetime prevalence overall. And then in 1999 study, the men who have sex with men, which is the term that I used a little bit earlier, had 21 times the average use of nitrite inhalants, 4 to 7 times for sedatives, hallucinogens, stimulants, and tranquilizers. Nitrite inhalants, it's a term. It's called poppers. I don't know if you've heard it, Joyce. I don't know.
Yeah, my people like to use it too. Not as much though. Not as much as your population, it seems like, but I have seen it before.
Yeah. So that's one that is very very popular within the LGBT, more the gay men that uses.
What I hear from these is it gives them a high too. But I hear so for my population, I see a lot of meth actually in the LGBT community that I work with, and I hear that they use meth as a party drug. Is that the same thing with the nitrite inhalants?
Well, it's more for sex. So
yeah.
meth, sex.
Yeah.
Exactly. It's all exactly. It's all one whole big party.
Yeah.
So yeah, it's very common within the gay population. Let's move on. And so 1998 study, the club drugs, there goes methamphetamine, hypnotics, ecstasy, THC, poppers used by the LGBT population was greater than heterosexuals. And then marijuana use is also greater than heterosexual. Cocaine, heroin, some research indicates higher use by LGBT people, but it wasn't conclusive. And then in college age, alcohol and drug use equal regardless of sexual orientation or practice. It's likely due to the higher use by everyone in college. That's kind of like the thing, right? Like college party time and all that. So that wasn't really much of a big difference there. And then the lesbian and gay less likely to abstain from alcohol than heterosexuals, and then lesbians at higher risk for heavy drinking than heterosexual women, and then gay men not at high risk for alcohol-related problems than heterosexual men. Older age and female gender were not protective factors against substance use in the LGBT population as they are in the heterosexual population. And then little evidence to support that the LGBT lifestyle, gender role conflict, or rejection of LGBT identity contributed to substance use problem. And then this study says that lesbian bi women had a higher incidence of than heterosexual women for alcohol abuse. And then lesbian bi women, same thing, higher risk with than heterosexual women for drug use, but not as robust as findings for alcohol. And then gay bi men do not have a higher rates of substance abuse than heterosexual men overall. Gay and bi men do have a higher than heterosexual men for drug use, but not much higher. So it's basically saying it is, but it's not, not extremely high. And then when analyzed separately, bisexuals have the highest substance use rates. Adolescents, overall illicit drug use rates for teens, it's around 21%. And then for the LGBT youth, much higher, as high as 95% have tried illicit drugs, including alcohol, as they are underage at some point. Overall, a meta-analysis, 190% higher use among LGBT youth. Rates especially high for bisexuals and lesbians. And then in the findings in this meta-analysis, there was an increased risk for substance use, most pronounced for young lesbians, high risks for bisexuals, and least pronounced for young gay men. And then by drug, high differentials were cocaine, heroin, cigarette, injection drugs, 3 to 4 times that of the heterosexual rate. And then the low differentials were alcohol and marijuana, and then used by widely all adolescents. Contributing factors: homelessness. 40% of the homeless youth are LGBT, and it leads to sex in exchange for money and food, risky drug behaviors, more likely to contract HIV, and then it leads to increased stress, poor mental and physical health, and less health care access, which, it makes sense, right? If you really think about it. Contributing factors: minority stress, differences in LGBT and heterosexual substance use. LGBT communities often center around bars and circuit parties, perceived normality of drinking, drug use, and then sexual minority, right? And so if you really think about it, right, like the heterosexual community has all these different spaces where they can go to and they can meet, and there's not that, you don't have to figure out, if the person is or isn't, right? It's a lot easier for the heterosexual population to, to meet, right? Whereas, like, for example, let's say a gay man is at the grocery store and another man sees them and smile, like, it's going to be very hard for them to go up and be like, oh, hey, can I get your number? Because that could have just been someone that was being friendly, right? Whereas when the heterosexual, population, they're at the grocery store, a guy sees a girl sees a guy, they smile, like, oh, hey, it's a lot, easier for them to go to each other and talk. And so this is basically mentioning that, like the LGBT population has bars and circuit parties to kind of like be able to help them, socialize, get to know each other, and then they know that there is like, okay, well, if this person's here, more than likely they're part of the community, so it's a lot easier. And then with all that comes the drinking and the drug use and all that. And then so the research limitations, and then how do you assess for sexual orientation, right?
Yeah.
And this is something that I experienced with regards to my to me working at the Long Beach Health Department. That's when I learned that term MSM, men who sleep with men. And the reason why that was used, and I didn't know this, and mind you, I'm part of the community, right? And so I didn't know this because there's a lot of men who sleep with men that don't identify as gay. Whenever I would see these men, they were like, I just don't identify as gay. I enjoy the sex with a man. But that's it. Like, and to me, like, this is a person explaining to me. They were like, to me, it's like, I feel like in order for me to identify as gay, I would have to have like a deep, like, to have an emotional connection, to have, all this other stuff, just rather than sex. Mm-hmm. And so then because of that reason, it's like they don't identify as gay. They don't identify as gay. They identify as straight, heterosexuals.
Do you identify them as gay, or do you identify them as straight because that's what they identify?
They can identify whatever they identify. It's not for me to decide what they're going to identify or not. So if someone comes into me and tells me like, no, I'm straight, I just sleep with men, then okay, you're straight, you're heterosexual, because that's what you identify as.
Yep.
And so then, and the whole reason for all this, right, is again, how do we assess for sexual orientation, right? And so that's where that MSM term came about, to see if we would be able to bring more of that population in, instead of, because if we use the term gay, then we would be missing out on those men who sleep with men that don't identify as gay, right? If we were to do a study and like, oh, we want to see, about the gay population, so then we would be missing all these men who don't identify as gay but are still sleeping with men. Mm-hmm. And so then in order for us to, just bring everyone in, men who sleep with men, it just encompasses and makes it a lot broader. And it's like there's no label attached to it. Right. Mm-hmm. And so like the other research limitations, like sexual identity, sexual activity, have bisexuals as a distinct category, like all these things, right? Like it can have its limitations.
A lot of variables.
Mm-hmm, exactly. And then, early studies recruited at bars and health centers are pretty biased, right? Yeah. If you're only going to bars and you're going to health centers, so then, you're going to find a lot of, if you're looking for, the incidence or the rates of chlamydia, and you're going to health centers, well, guess what you're going to find? You know what I mean? So the lack of resources and initiatives, bias against the LGBT people, bias against mental illness and substance abuse, and then lack of emphasis on prevention for substance use as well. And so this, the question that you asked with regards to the transgender population, right? Is sexuality versus gender, and then creating that space. Substance use, culture difference, methamphetamine, meth versus mania, ADHD, sex, unsafe, homelessness, naltrexone, gabapentin, Wellbutrin, marijuana, all these things, they're very common in the LGBT trans population. And then this is, like I mentioned earlier, with regards to when you mentioned what diagnosis I would see most, CPTSD, PTSD, and then I realized that a lot of the times CPTSD and then BPD can mimic bipolar disorder.
That's what I found too. It's gotten really hard. I want to say, especially over the last year during the pandemic, a lot of people are coming with all these mixed symptoms. So, I mean, how do you differentiate between CPTSD and then bipolar and the borderline and all those things?
It's tough. I'm going to say it's tough. It's really, really tough, right? It's really tough because it's like they present, and it's like you right away want to be like bipolar disorder because they're manic, but then like you start doing, I think it's all a matter of getting a good history, right? And I think if you're able to do a good history, and you're able to like for sure be like, okay, you've had this before the pandemic, you've had this, and there was an episode, and you're able to check off all the boxes, all the criteria. It's nice when it's like that, because it's like, oh, yes, bipolar disorder, I know that. But then when they come in with all this mixture of complex post-traumatic stress disorder, BPD, all this other stuff, you're just like you just have to continue following the patient, hopefully that they keep coming back to you. And then as you start doing more questioning and bringing more out of them, then you're able to I think like have a better like grasp of like, okay, yeah, like now I'm able to see. But I don't think you'll be able to get that like with someone like a patient like this, right? That comes in like again with CPTSD, with BPD, and like all this other stuff, right? Like it's not gonna be as easy as like when the first time that you meet them that you're gonna be like, okay, this is what this is. It's not that black and white. And so I think it's just a matter of continuing to follow the patient. At least that's been my experience. I don't know what your experience has been.
No, it's exactly the same way. Oftentimes I don't diagnose on the first visit or the second or the third. It often takes, because a lot of times when people give you history, they don't really know what symptoms they're having either, right? So their assessment, because especially for like bipolar, right, most of them get misdiagnosed like 2 or 3 times before they get the right diagnosis, I think was the last statistic I heard. Right. Because they always present to you as depressed because they're depressed. They don't care about the mania. They like the mania. So it's the same thing with all these other disorders too. They only want to talk about what bothers them. They don't see all the other symptomology that maybe their friends or family might see. So it often does take a long, long time to draw that out and get a much better picture. And if the medication doesn't work, then that's another side.
No, and that's you have asked about like the diagnosis that I see the most, and the other one is ADHD.
Oh, okay.
And it's how ADHD can sometimes also be misdiagnosed. Bipolar disorder, like there's a lot of similarities with that, and I'm seeing a lot of that. And so the good thing is that I always like to do like a really thorough history with regards to like, like how did you do in school? Like, did you get in trouble in school? Like, at home, would you get in trouble at home? Like, I always ask those questions. And a lot of patients that come to me with like ADHD diagnosis, like that are adults, I always go back and like, I mean, I'm just asking these questions, right? And I'm like, oh no, like I got straight A's, and I would never get in trouble. I was like a really good student, and I would never get in trouble at home. And if I would get in trouble, it was because like I got on top of the roof, or things like that. And it wasn't like all the time. And so whenever they come to me like that, and I'm like, when did you get diagnosed with ADHD? Like, oh, like in my mid-20s. And then I'm like, okay, in your mid-20s, all right. And then I'm like, okay, well, let me ask you now this other set of questions. Did you ever have any racing thoughts, or you couldn't sleep?
There you go.
The bipolar diagnosis, like, yes. I'm like, hey, guess what?
It's not ADHD.
It's
probably not helping. Probably making it worse.
Yeah, but I've seen a lot of that. I don't know if you've seen it in your practice where patients get misdiagnosed with ADHD, and
yeah, it doesn't help. I mean, we're talking about a different subject now, but with ADHD, I find that there are definitely less scrupulous providers that kind of just write whatever you want, and they don't really do their due diligence to ask the right questions to get them what they actually need.
Right.
And then we have to clean up whatever they've done. So it's
and you say it's like, it's actually not a different topic, because it's part of the topic, because again, part of the complexity, right? Of whenever you get a patient and they come in and they're going to be like, I have ADHD, I was diagnosed, and I've been taking Adderall, and it's great, and it helps me. And it's like, okay, let's do the intake, and let's talk about this. And you start asking all these questions, and you're like, this doesn't add up. And like you're saying, a lot of the times providers, and that's what I tell all my patients, a lot of the times you'll go into a provider's office, and you can just let them know, oh, I'm having trouble concentrating, I can't focus. Oh, you have ADHD, here's Adderall. You take the Adderall. Oh my God, it helped. And then, so yes, I do have ADHD because the medication that I was prescribed helped. I'm like, that's not the case. I'm like, because even people who don't have ADHD can take Adderall, and it's going to help them, right? Not all of them, but the majority of them, it will, right? And so not because the medication helped does that mean that you have the diagnosis. That's why, a lot of these, stimulants are being used in college, right? And that doesn't mean that all those college students have ADHD. Yeah. And so it goes to to what I'm speaking about, when you have these patients that come with all these, diagnoses, and trying to understand and unravel, and it's difficult. It's difficult because they present a certain way, but you have to ask all these questions, and once you start asking all these questions, that's when you start getting okay, you could have been misdiagnosed.
Yeah, and misdiagnosing is very, very common. And it's very common, too, to change the diagnosis as well, because people change over time.
Exactly.
So,
yeah. Let's move on. So HIV is very prevalent in the gay community. And so, knowing the changes in treatment, the challenges, right, like medication fatigue and compliance and psychiatric side effects, right? Some of these medications can have psychiatric side effects, right? So that's another thing. Is this being caused by a medication? It's not being caused by a medication. Those are also things that you also have to take into consideration when working with this population. Then transgender care and cultural, right? Anger, because of the transgender. So there's the LGBT, right? Lesbian, gay, bisexual, transgender. And so for the longest time, and even up until now, it started shifting. But like the transgender population, even though they were part of the LGBT, they felt like they were outcasts, they weren't part of fully of the LGBT population, right? And so there was this anger from that, from not feeling like they were part of the community. And so take that into consideration. I've had my experiences with patients who are transgender that have come to me, and I feel like there's a lot of resistance a lot of resistance. There's a lot of anger from that population. I feel like the transgender population, it's like a population on their own. And so it's slowly starting to shift where it's starting to be more accepted within the LGBT population. But know that there can be anger. Try not to be judgmental. Things not to say. Don't give opinions. Create space for the conversations. Ask what pronouns they want to be referred to. So as an example, like if I start, like Joyce, right? Let's use an example. Like if you were a patient and I would, start the intake, I'd be like, Joyce, what pronouns would you like for me to refer you as? And you can say she, her, and then so like I know that those are the pronouns that you want me to use when I refer to you. So always asking, if you're going to be working with this population, asking what pronouns they want to be referred to. Sometimes they're non-binary, so they'll say they, them, right? And so you refer to them as they, them, instead of, she or him, there's they, them. Dead names, what a dead name is basically like the name that was given to that person at birth. And so if they're transitioning, they might say that that's their dead name. So like, for example, if my dead name would be Robert, because like now my name is Victoria. And so like then my dead name would be Robert. And so always be careful not to use the dead name, because sometimes it can be very triggering. And so fortunate at the center, because we work for the LGBT population, right? Within their medical record, they have, the name that they want to be referred to. Okay. So it has their legal name, but then in parentheses, like they'll ask, like, what name do you want to be referred to? And then so they put them in parentheses. So whenever the patient comes in, like whatever's in parentheses, that's what I refer them to. Like I don't refer whatever their legal name is. And at times I do have to, because for instance, like if I'm, sending a prescription over to the pharmacy or calling it in, I have to ask, like, listen, like I'm calling it in or I'm sending it into the pharmacy. What's your legal name? Is your legal name like, I won't even say this, like your dead name and your last name, and they'll be like, yes, okay, so I'll use that. Or like, no, like it's, I already changed and now it's Victoria, it's not Robert anymore. So, okay, great. But yeah, always ask. It's always polite to ask. And then so, yeah, there's actually, like I mentioned, like the transgender clinic that they opened. So it's going to be trans care. And so, yeah, I mean, they already had trans care. Like, I don't think that, the trans care just came about. Like, they already had it, but like now they opened like a clinic to specialize with just the trans population. But before, they would get the services where I worked at the Hollywood Center. Okay. And then so permanent versus temporary changes. So permanent would be, someone that goes through surgery, and then temporary would be like someone who cross-dresses. And so consent for surgery is not your opinion on surgery. It's like, don't give your opinion with regards to like they shouldn't. Like it's their process, it's their journey, and there's no need for hormones in California. If psychosis is not it's not a contraindication. So schizophrenic spectrum disorder is not a contraindication. Ideally, it would just be managed, and then it can still be considered if psychosis does not directly relate to the gender identity. If the psychosis were to directly relate to gender identity, then that's when it would be questioned. And there has been studies that have shown that when patients transition, it can improve their psychosis. And then, like I mentioned earlier, like a lot of this population moved to LA to get the treatment at the LA LGBT Center, because it's, again, the world's largest LGBT center. And then Medi-Cal too.
I have a quick question on this. So I see that consent's not needed for hormone treatment, but is consent needed for, and by consent, is it like that the psychiatry has to clear them first? Is that what they're talking about?
Right.
Okay.
Right.
Okay. So do
Right.
you need consent for surgical?
Yes. So
Okay,
you would,
but not hormone.
yeah, right.
Okay.
Right. So yeah, so what would happen is, excuse me, so they go see primary refers them, and basically they have to do 3 classes.
Okay.
And then once they complete the 3 classes, then the psychiatrist signs off on the letter and then gives a letter to the patient, and then the patient submits that to their insurance.
Okay. So the patient has to do 3 classes, or
Yes.
okay. So the provider. So if I wanted to be able to clear people for the surgery, do I have to take any special classes to do so?
Oh, that's a really good question. I don't know. I'll have to get back on you on that. And the reason being is because at the center, the director of psychiatry, which is the psychiatrist that I'm under, he's the one that does the letters.
Oh, okay.
He's the one that signs off on them. But that's a really good question. I'll get back to you on that, and I'll let you know to see if there is or isn't something.
Yeah, and I'll add the answer somewhere here.
For sure.
Okay.
Like I mentioned, we have integrated care. It's the third floor clinic. They have medical social workers. There's therapy. There's ARS and the Stop Violence. And so there's ICP and MDCC, and then the THP MDCC. I am really bad with like what they stand for. I know that I know they were going to ask me. ARS is addiction and recovery.
Okay.
ICP is interdisciplinary care program, and so basically, like, and I'm part of that. So that's therapists and the primary care and psychiatry. They meet up and discuss patients who are having difficulty or struggling. Then that's where ICP would come in to kind of we would discuss the patient and see what the proper treatment would be. Medical care coordination, so multidisciplinary care coordination. So very similar, but that's more for the medical part. ICP is more for therapy and psychiatry, and MDCC would be more for medical. And then so THP, I don't know what THP stands for, but that would be specifically for. I know the T is for transgender. So that would be multidisciplinary care coordination for the transgender population.
Okay.
And then so MDCC is just for like the gay, lesbian, bi, everyone else. But the T, I don't know what the H and P stands for, but I know that that's specifically for the transgender population. Any questions about that?
Nope.
Okay, awesome. And then so like you had asked, like it's 1 hour intakes and then 30-minute follow-ups, and then we have the on-site pharmacy. Patients can apply for the temporary disability, the ESA, which is the emotional service animal letter, benzos and stimulants. We have policies. We don't prescribe benzos. Stimulants, they have to do a stimulant contract, and so it's just really we work with a population that has a high incidence of substance use, and so we try to kind of limit the benzos and stimulants that we do prescribe. And so like right now we're going through this process where we're tapering all of our patients off of benzodiazepines. We're not prescribing them because, as you know, like these medications are not meant to be prescribed long-term use. They're meant to be prescribed for 4 to 6 weeks. But before, like they worked really well. They were great medication. And so everybody was just like, yes, you get a benzo, you get a benzo. Everyone gets a benzo, right? And then it was like not for the 6-week periods. It was like, like I've had patients who've come in who like, I've been on this for 20 years. Mm-hmm. And it's like, I tapered a patient off that was on Valium. He had been on it for 20 years. And it was the most difficult thing that I ever did. And the feedback that I got afterwards, he was just so grateful and thankful. He was just like, oh my God, like if I would have known, like this medication was causing more anxiety than it was actually helping my anxiety, because like now, like it's like I'm not feeling that anxiety that I was feeling like before that I was on the medication. Mm-hmm. So something to keep in mind, even if you work for the LGBT population or you don't, as a provider, like just be I mean, I speak on behalf of myself. I'm very conservative when it comes to prescribing vasostimulants, and I'm really well known for that.
That's not a bad thing to be known for, though. You know, you care about your patients. You care about their long-term health. So.
Right. And so that kind of goes into the prescribing practice as well, right? And then that's it. And if you guys have any questions, concerns, or complaints, let Joyce know, and I'm sure she'll
no complaint. There's no complaint. Everything's good. Okay, so thank you so much, Robert. This was super educational, really fun. I hope you viewers got a lot out of this as much as I did. I learned a lot of new things today. I'm going to put his information in the description box below and somewhere on the video. So if you guys have any more specific questions about what it's like working with the LGBT population, please reach out to him. He's a great resource. Awesome guy. And just to let you guys know, I plan on doing more interviews with more people that work in psych. So if you follow my Instagram, periodically I'll be posting stories asking for any questions that you guys might have that I can then ask my interviewee, whoever it's going to be. So that's what I did for Robert, and I got some really awesome questions. So continue to do that. And thank you guys so much for watching. I will see you in the next video. See ya.
Bye, everyone.
So to start off to celebrate the beginning of our very first, to start off with the beginning of our, what?
Start all over?
I don't want to start all over, no.